Welcome, everyone. We're pleased to be bringing you the second part of your webinar series in partnership with the National Association of State Head Injury Administrators and also with Dr. John Corrigan and April Turner. My name is Judy Detmer. I am the Director for Strategic Partnerships at the National Association of State Head Injury Administrators. Many of you have watched the first part of our series, which is a pre-recorded webinar that is called What If There Is a TBI that Dr. Corrigan recorded for Alabama. And if you haven't watched that already, please do take time to watch it. It will give you some great background information for some of the information you're about to hear. Today's webinar is a follow-up to that presentation, really geared toward you as mental health professionals to get a little bit more into what do you do once you understand someone has a brain injury. It's an interactive question and answer format, so we're hoping that you'll find that enjoyable. There are no CEUs or evaluations with this particular webinar. Next. As I mentioned, today our presenter is Dr. John Corrigan. Dr. Corrigan is a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University and director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. He is the editor-in-chief in the Journal of Head Trauma Rehabilitation. Dr. Corrigan directs the Ohio Brain Injury Program, which is the designated lead agency in the state of Ohio for policy and planning related to people living with brain injury. He is a member of the board of directors of the Brain Injury Association of America and has previously served national organizations including CARF, the Injury Control Center at the Centers for Disease Control, the Veterans Administration, the U.S. Department of Defense, and the Defense Health Board. Dr. Corrigan has more than 160 peer-reviewed publications and has received many awards for his service and research in brain injury rehabilitation, including the Brain Injury Association of America's William Fields Cavanis Award, the 2007 Robert L. Moody Prize, and the Gold Key Award from the American Congress of Rehabilitation Medicine. We also have with us today April Turner. April Turner is currently the State Head Injury Coordinator for Alabama's Department of Rehabilitation Services. She is also the Program Director of the ACL Partnership Grant, State TBI Pre-Vocational Care Coordination Program, and statewide TBI SCI Trauma Registry Services. She received her bachelor's degree in rehabilitation from Troy University in 1999, then her master's in rehabilitation counseling and vocational evaluation from Auburn University in 2001. For 19 years, her work includes vocational evaluation, welfare to work, transition, voc rehab, general counseling, and special TBI care coordination. Ms. Turner currently resides in Opelika, Alabama with her husband Chad and two sons, Cam and Cole. We're very excited. Next slide, please. Very excited to be bringing you this presentation. Just a brief disclaimer, this presentation was prepared for the Alabama Department of Rehabilitation's TBI Administration for Community Living Grant with mutual agreement of understanding with Alabama Department of Mental Health. All material appearing in this presentation, except that taken directly from copyrighted sources, is a public domain and may be reproduced or copied without permission from ADRS or the authors. Citations of the sources is appreciated. Do not reproduce or distribute the presentation for free without specific written authorization from the Alabama Department of Rehabilitation. And for more information, you can contact April at april.turner@rehab.alabama.gov. The opinions expressed herein are the views of April Turner and Dr. John Corrigan and do not reflect the official position of the Alabama Department of Mental Health. No official support or endorsement of ADMH or SAMHSA for the opinions described in this presentation is intended or should be inferred. Next slide. So as I mentioned, I'm Judy Detmer and I'm with the National Association of State Head Injury Administrators, and we are very pleased to be partnering on this project with Dr. Corrigan in April to bring this to you all in Alabama. We all know that behavioral health and brain injury is significant, and we're very excited that Alabama has this initiative going on. NASHA is a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. For more information about our organization, you can go to nasha.org. And with that, I am going to turn it over to April.
Sure. Thank you, Judy. And good morning. Good morning to everyone in Alabama as well. We have been screening those in our state mental health system, and many of you have been doing those screenings for us to screen those who have traumatic brain injury. And we have gotten many questions regarding, we've screened them, some of them have a positive screening. Now what? What should we do? So now that we know they have a TBI, this is why knowing matters. One of the first things is having a history of TBI, often hidden among those receiving mental health services, is very important to know. So we're discussing in the MI system, the DD-ID system, and also in the SA. Having a history and knowing that they have that history is very important. If a provider, community health provider, knows or suspects that there's a TBI, they can engage from the start as well. They can make right referrals and also adjust their treatment plan once they know that they have a TBI. Mental health providers or community providers can also make simple accommodations to better support the individual's deficits, and also they can provide psychoeducation to the consumer so they can advocate for themselves. One recent study a study also found that 42% of persons who indicated they had incurred a TBI, as defined by the CDC, didn't receive medical treatment at all. And that was Corrigan and Bogner in 2007. And also TBI has been defined as a silent epidemic, or with our veterans, the invisible wounds of war. An estimated 5.3 Americans currently live with identified disabilities caused by TBI. Estimated 2 million Americans sustain a TBI every year. And here in Alabama, we have an estimated over 10,000 Alabamians who sustain a TBI every year. Next. Why do we have a need for TBI services or treatment inside our mental health system? Individuals with TBI are already coming to the State Department of Mental Health, their community providers, and substance abuse programs for services, and some of them are already receiving services. The bulk of the provision of mental health and substance abuse health is through our state mental health systems. There are other public providers as well. Alabama does not currently have funds or programs earmarked specifically for TBI mental health treatment, TBI substance abuse support, and TBI specific long-term care. Next. So first, we would like to provide some initial resources before we turn over some questions to Dr. Corrigan on who do we contact. Many of our providers do serve those, and I'm speaking of mental health providers, serve those who have TBI. But there's some that when they walk in the door, they don't really know where they need to go or where they need to find information. So this is where we start. Here in the state of Alabama, there's some support for you for TBI. There are TBI programs. With state support, and this is who I work for, the Alabama Department of Rehab Services, we're the lead agency on brain injury. We currently have an information hotline, and that number is listed here. You can call it any time. It comes directly into our office, and we have someone to help support your questions regarding TBI. And some of you are already aware we have a website that is supported by our TBI grant. That is www.alabamatbi.org. There we have our specialists listed. We currently in the state have pediatric and adult TBI care coordinators. They're counselors. There are pictures of them, their regions, their numbers, and their emails. You can contact them directly. It is all on that website along with trainings. Some of you are aware that on this particular website, you can hit the mental health button and down comes a list of trainings, including what if there's a TBI with Dr. Corrigan. There is training as well on our screener. the OSU TBI. And also, we currently are in production of having Alabama Traumatic Brain Injury Virtual Resource Guide uploaded, which will have a statewide list of resources for those who have TBI. You could also print off a page, so it could be a community health provider, a parent, any kind of family member, or the survivor themselves could go to that website and print off any of the pages of resources that we'll have there, and that's soon to come. The website for our state department is rehabalabama.gov/TBI. There are one-pagers there that have all the listed services in the state of Alabama. In particular, our children's rehab service, our adult ICBM, which we call the TBI program, our state of Alabama independent living program that serves people with TBI, and also our vocational rehab program as well. We have a nonprofit that we work hand in hand with. They are called the Alabama Head Injury Foundation. So you have your state services, and we also have a nonprofit directly serving those with TBI and spinal cord injury. And that is www.ahif.org, ahif.org. They have resource coordinators around the state, like we have TBI specialists, and we work together. They provide ongoing support groups, TBI resource camps, respite care, and resource coordination. Right now, they're doing a lot online as well, despite COVID. So these particular resources, if you have someone that comes in and you don't know how to help them, or if they test positive, these are the resources on where to start. And you can simply just give them the alabamatbi.org address. They could go there, or give them the hotline number, and that would show them where to begin. Okay, and today we want to thank Dr. Corrigan for being with us all the way from Ohio, and we have some questions that our mental health providers have come to me and have asked me and would like specifically detailed answers, and these are the ones we're going to review with Dr. Corrigan today. So we're going to get started with the first question. Good morning, Dr. Corrigan.
Well, good morning, April, and thanks so much for having me. We're doing this virtually. I would have much preferred the original plan, which was to do it in person and get a chance to come back to your great state. I think it was in March or April this year we had to cancel that. And
we did. Well, so, thank you so much for doing this.
Maybe I can come back in the future. But,
yeah, we hope so. Thank you so much, and we really adapted. And this is live. It's live, so I get tongue twisted a little bit as well. And we're just appreciative that you're doing this with us online, very much so. So we're going to get started with the first question. Why do I need, if I'm a mental health provider, why do I need to know about brain injury in my treatment of behavioral health problems?
Well, and this is a great question to start with, April, because we all want to know what's relevant. We're all, as providers of various healthcare services, we're being inundated constantly with new ideas and new thoughts. So it is a good question. Why do I need to be concerned about brain injury in my clients? And the answer is going to be twofold, and I'm going to show you a few slides that support that. But the first is that it's really common. You are already treating a lot of people with brain injuries, so it's not necessarily new. And the second is that many of these individuals have a unique presentation because of what I call the fingerprint of brain injury and how it affects a person's behavior. So let's look at a little more detail. So these percentages here show in just the general population of adults, these are taken from 3 different states, how many people have had a traumatic brain injury sometime in their life. And so any traumatic brain injury at all, 43%. A little bit more important, as we'll see in a moment, are those traumatic brain injuries that actually result in loss of consciousness. And here LOC means loss of consciousness, not level of care. But some 1 in 4, 1 in 5, just adults out on the street have had a TBI that has resulted in them being knocked out. And even more important, like 1 in 20, 1 in 25 have had a moderate or severe TBI. And With a moderate severe TBI, we know that there will for sure be some kind of residual. It may not be disabling, but there'll be some kind of effect in terms of a person's life. So that's the general population. If you just grab people off the street, those are what you'd expect. But if you go into substance use disorder treatment programs like we did over a period of time in Ohio, you get quite a bit larger numbers. So twice as many people in treatment for substance use disorders. And this was in our community-based treatment programs, our publicly funded programs. Twice as many have had a TBI with loss of consciousness, and almost 4 times have moderate or severe. Studies of psychiatric inpatients have found similar rates that quite a bit elevated over the general population. So these folks are on your caseload, is my point. And this is not unique to behavioral health, but essentially anywhere where you also see behavioral health problems, you will see relatively large prevalence of traumatic brain injury, whether among prisoners or those homeless. I could show you victims of intimate partner violence. And in all of these, we would be seeing these elevated rates over just the general population. So that's the first part of the answer. Why should you be concerned? It's that because you are treating these individuals. But the second part has to do with then how traumatic brain injury affects the individual. And this is a very important idea, and that's that no matter where the brain, there's an impact on the head, whether in the back, the front, the side, whether it's caused by falling and hitting your head, or somebody hitting your head, or even being shaken, wherever it comes, there may be bruising in one spot where the impact is, but there's almost always additional injury in the frontal areas of the brain. And what's the implications of that? So this shows how the head gets kind of set in motion various ways, and the inside the head, the brain floats in kind of a gelatinous material, and if you have this exchange of energy, this movement, it kind of does this. It jiggles inside the cranial vault, and for the most part, that's okay because the inside of the cranial vault's nice and smooth. However, towards the front, there are these bony ridges here that you see here. And if you get enough jiggling, so if there's enough force to the head and the brain jiggles inside, you're going to get scraping and bruising in these areas where the bony ridges are in the front of the brain. So that's why kind of no matter where the blow comes to the head, you get this injury to the frontal areas. And we've seen this whether in autopsies done early on or more recent CT scans. You see that it's the front that has the injury, no matter where else there is bruising or shearing. More recent methods used to look at the connections inside the brain also point to the frontal areas as a major focus of where damage occurs. And what I'd suggest to you is that if you're going to damage a part of the brain, that the frontal lobes are not the ones to pick, that they are really essential to our success in getting along in society. The frontal lobes are, as a proportion of the total brain, the largest in humans. They develop the most from childhood up into our early 20s. And they also do a lot in terms of regulating our emotions and regulating our behavior. And it's that loss of regulation that really leads to, sits underneath many of the problems that you treat in behavioral health, whether psychiatric or substance use disorders. And so you see here in terms of abilities that are kind of subserved by these frontal lobes, initiation, problem solving, judgment, inhibition. These are critical issues to maybe first not developing problems, and then later, if you have a behavioral health problem and you're in treatment, your ability to respond to treatment will be affected by weaknesses in these frontal areas. So So that's the fingerprint. And, I've mentioned bruising, but it is also these connections from the mid to the front. And, that particularly can be sheared or torn when the brain is jiggled about. Now, you may think this is a slide about brain injury, but actually this is a slide about addictions. This is showing the dopaminergic system that kind of underlies most addictive behavior. I could also show you one that shows the kind of the course of the serotonergic system as it courses from the midbrain through the front and to the back, and how which is also implicated in as an underlying vulnerability in terms of all kinds of psychiatric injury. So that's the fingerprint of traumatic brain injury. That's not, that's why maybe are such high rates of behavioral health problems in this population in persons who have histories of brain injury. But it also means that you're going to have kind of a unique presentation of folks with this history, that their so-called executive functions, so their ability, their insight into their own behavior, their ability to anticipate others' behavior, their awareness of their problems, their attention and concentration, their memory, all will be affected by this damage to the frontal lobe. I've been talking about traumatic brain injury, which is one kind of acquired brain injury, but I would be remiss not to also mention anoxic or hypoxic brain injury. And this is when oxygen is denied to the brain. And it's what we see very commonly in overdoses of all sorts, but particularly, obviously, opioid overdoses. We also see it very commonly in victims of intimate partner violence, where they've been choked, maybe and hit in the head. And recently, even folks who've had more severe bouts of COVID, where there have been disruption of their breathing, may have experienced some anoxic or hypoxic injury. And when the brain is denied of oxygen, the parts that are more affected are the big users of oxygen, the parts of the brain that are really the heavy oxygen users. That includes the hippocampus, which is involved in memory, and that's why there's often memory problems. It involves the cerebellum, which has to do with fine motor coordination. And it has to do with it. A big user of oxygen is the medial forebrain bundle, which is that general area that I was showing you before, that has connections into the frontal lobes that subserve the ability to regulate behavior and regulate emotions. So it's not just traumatic brain injury; it's also these like anoxic and hypoxic brain damage, as well as other kinds of acquired brain injury. If you had a stroke that affected the frontal lobes, you can have the same kind of so-called executive function weaknesses. And as we'll talk about more before we're done here, those weaknesses can have a lot to do with success in treatment.
Yes, and specifically, you have seen with what Dr. Corrigan just said, those effects from just brain injury. So when they come in for our providers, they're having severe mental illness or depression, in addition to all of these executive functions that may be missing. So how do you see that these consequences of these brain injuries may affect their treatment inside the mental health system?
So, April, there's a few things I think are important to mention in terms of the effect, and they all have to do with why there are additional challenges for people with brain injury when they seek, I say here, substance use disorder treatment, but really this applies to any behavioral health treatment. And it doesn't mean that they need a different treatment than from somewhere else, but what it means is, with as a provider, your awareness of these weaknesses and some accommodation for them, you can make the treatment experience as effective. But the first challenge that we notice is that these frontal lobe behaviors, often there's no sign of them, there's no scars or anything that would tip you off, but that damage affects their regulation of their thinking and feelings and promotes disinhibition, and that behavior can be disruptive to the treatment process, whether it's how it affects their interaction with the professional staff, how it affects their interaction with other program participants, or even how it affects their ability to get themselves to the right place at the right time. This frontal lobe damage can affect the kind of behavior presentation that you see. Part of that is not always detecting social rules and being aware of the impact a person is having interpersonally. So not uncommon, for instance, is somebody who doesn't realize they're violating somebody else's space by how close they stand, or maybe making physical contact. They may not realize that they are dominating. They're speaking. They're talking too much, and that they're not sharing the time in a group or in a discussion. And you can get the reverse too. You can get somebody who says nothing and doesn't realize that appears like they are disinterested when they in reality just may be listening. So not this poor perception of social rules, or less capable of seeing social rules, often gets them in trouble, particularly with fellow clients. So if you're in some kind of milieu setting like an intensive outpatient or a recovery center where clients are interacting with each other, sometimes the person with a brain injury becomes kind of the focus of frustration or irritation by other consumers and clients who are there. Another challenge that we see and often overlook is simply that there's a certain cognitive demand or cognitive load, as we sometimes say, required of our treatment. That we are expecting somebody to have some minimum levels of attention and concentration, or memory, or endurance, cognitive endurance. And so because so much of our treatment is done by didactic training, where we're talking at folks, or group interventions, that those those ways of providing care actually require more cognitive abilities. And so this is where the cognitive impairments, the attention, concentration, memory, problem solving that comes with frontal lobe damage, may be setting somebody apart from their fellow clients and reducing their ability to benefit from the treatment. Finally, the one that to me is the most egregious is the misinterpretation of neurologic problems as resistance to treatment, when really what you're seeing is just somebody with neurologic issues. So the common example I give is the individual who has poor memory, poor organization, poor planning, and are expected, into the program a certain day, and they neglect to set their alarm, or they neglect to tell their their mother or whoever they're living with that they need to be up that day early to get to the program. If when they do show up, professional staff confront them for resistance to treatment, for them that is totally misunderstanding what happened. That it is for them, they simply forgot something. They may be very interested in their treatment, and so the relationship gets off, or to a bad start, because here's the professional saying they are doing one thing, and from their experience they actually just forgot. In brain injury rehabilitation more generally, we would never expect somebody to make an appointment without a reminder, within 24 hours of being there. It's just part and parcel of the population. And so what I hope in the behavioral health world, just like when we finally recognized that trauma-informed care was a perspective that when we took it, we understood our clients better. We're hoping that recognizing that some folks with neurologic weaknesses, that we would, when we see a behavior, we'd ask ourselves as a professional, am I seeing a neurologic weakness, or am I seeing a psychologic or motivational, an indication of motivation? And if you jump to the latter, the motivation first, and you're wrong, you will have undermined the relationship. If you look at the neurologic and consider it first, and you're wrong, then it's not, you can move on to, well, this is actually, resistance to the treatment. So this is a big one, I think, and I think it's probably one of the most important things that we're trying to do in terms of making providers more aware of brain injury.
Okay, so how would I know if a client has a brain injury? And Dr. Corrigan, we've been doing some screening, some of our community health providers in the state of Alabama, and some of those have tested positive and some of those not. But how would I know, if I didn't have a screener as well, how would I know if a client has had a brain injury?
I'm not going to go back over screening because that's elsewhere on the website, about how to actually do it, though I'll mention the screener. But I want to kind of just back up a little and, just kind of a fun thing here, give you a little question, and that is, which of these is the best answer to the question? TBI is A, a life-altering injury for survivors and their families, profoundly impacting the patient's functional status. Or TBI is a very common injury that is essentially inconsequential to the individual's functional status following recovery. Or C, it's both A and B and everywhere in between. And of course, because you are all good test takers, you know that the right answer here is C. But because it is the right answer, it is true that traumatic brain injury can be everything from essentially a blow to the head that you have maybe a few symptoms for a few days or weeks and then it goes away, or all the way to a very severe injury that affects all aspects of your functioning and changes your life and your family. It is the whole realm. And that is so true that I can say to you that if I told you I have had a traumatic brain injury, you essentially know nothing more about me than if I were to say to you, my name is John, because a traumatic brain injury can be so many different things. And it is confusing, that the house, there are many things you need to understand to fully evaluate how likely is it that this person in front of me has some of these executive functioning or frontal lobe kind of weaknesses. And I think it's worthwhile just to take a moment. I realize this was in the other training as well, but just to kind of review the basics of the severity of a traumatic brain injury. And if you think of it along a continuum from least to most severe, the first thing, on the least severe side, are when the brain injury just causes somebody to be dazed or confused or maybe have a gap in their memory, but they aren't actually knocked out by the blow to the head. The next most severe are when that injury causes loss of consciousness. And then the most severe are when it causes coma. And coma, not only are you knocked out, but even some basic reflexes and that kind of thing are not functioning. Now, if we had been smart, we would have called the first mild, the second moderate, and the last severe, but we were not that smart. So instead, in the brain injury world, we call mild TBI all of the first part, the just dazed and confused, as well as some of the injuries involving loss of consciousness. And know that mild TBI is a concussion. Those are just different words for the same thing. Then a moderate TBI is almost the rest of all the loss of consciousness. And then the severe is some of the prolonged loss of consciousness as well as deeper levels of coma. So, our nomenclature, it doesn't make it easy to understand severity. But if for you who are not brain injury professionals, if you just knew a couple of different mileposts along this severity continuum, you'll know a lot about the brain injury history that a person's had. And the first of those mileposts is there any loss of consciousness at all? If there is, then we know there's a greater likelihood that there's going to be some residual weaknesses or in cognition or emotional regulation and behavior. So any loss of consciousness is an important milestone. A second one is, was that loss of consciousness 30 minutes or longer? Because that pushes them into that moderate and severe area where we know it's near certain that there will be some kind of residual effect, even if it's not outright disability. So when you're thinking about severity and when you're doing screening, you need to at least get these two pieces of information about a person's history. Have they ever had a traumatic brain injury that caused them to be knocked out? And if they did, was it longer than 30 minutes? And the screening tool that you've adopted there provides that information. Now, just to make sure that it wasn't just that easy, having residual symptoms is not just a matter of severity. There are some other issues. And one of the big ones is cumulative effects from multiple, even very mild traumatic brain injuries. And you already know something about this because sports-related concussions have been in the news for some time now, as have the injuries that our service members experience from blasts, as well as traditional ways of getting brain injuries in Iraq and Afghanistan. And the big question about these repetitive blows to the head, is it the sheer number? Is it the number of times it happens, or is it the spacing? And I will say to you that right now we are a little more interested in spacing than in number. Though, there may still be a number that's too many, even if they're spread out over time. But certainly, if you have not fully recovered from the last traumatic brain injury, and then you get another one, that's going to be worse than just a mild TBI. So these repeated blows is is another factor, not just severity. And this may feel a bit remote when we talk about military personnel, though I'm sure you're working with lots of veterans and even current military service members, and nowadays with lots of athletes or former athletes. But there are some other groups that you need to think about in terms of multiple mild traumatic brain injuries, and that's victims of intimate partner violence have had multiple blows to the head as well as anoxic events from being choked. That people who have at-risk substance use, once you start drinking regularly to intoxication, falling down the steps, falling, getting in fights, having car crashes, all the incidence of all those things go way up. And it is true of other vulnerable populations as well, that as we saw earlier. So all these groups have these multiple milds, so any one of their injuries may not have been too severe, but by having too many of them or too closely spaced, more importantly, they may be showing the signs as if they had a more severe injury. If you've looked at the screening device, you know that that in addition to both severity and cumulative effects, then we also are interested in the age of injury, and particularly we think that childhood, having a childhood injury, even when mild, may lead to more problems of adult self-regulation. We often forget when we're getting history that having a recent one makes a difference. If it was just last week that I was fell and hit my head and had momentary loss of consciousness, so then I'm probably not functioning at my best right now. And then if you combine a history of brain injury with other kinds of neurologic conditions, whether that's maybe a developmental disorder or attention deficit, or as I've already been mentioned, like in intimate partner violence, where you combine a anoxic event or hypoxic, where you're denying oxygen from strangulation, and there's blows to the head from being hit. So, the screener that you're using allows you to get at much, not quite all, but much of this information, and it's designed to try to get to the key information quickly, so you're not spending a lot of time screening. It's called the OSU TBI identification method. I believe that there's probably screening on April's website, but I did leave this here. It's just a structured interview. And, it does make a difference on how you ask. You got to help kind of remind people of incidents in their life when they might have had a blow to the head, and then having identified that, see what kind of altered consciousness or loss of consciousness that went along with it. And then once you do have all that information, you know how old they were, what their worst one was, what their if they may have had repeated injuries, a period in their life when they had repeated injuries. So it provides way more information than just simple yes, no, than just simple, my name is John and I've had a traumatic brain injury. Does not tell you enough. And this is just the landing page for the online screening, all of which is free for use, and that's what the form looks like. And I agree, it looks a little complicated when you look at this, but I know from having trained a lot of folks, if you just practice it twice, it just becomes second nature almost. And a lot of people talk about having just incorporated these questions into the natural flow of how they do assessment.
Mm-hmm. And those 5 questions are very easy. We have found from the pilot sites here in Alabama, they're very easy to go through, very quick. And they can find those on our website. So alabamatbi.org. If you go to mental health, you will see Dr. Corrigan's What If There's a TBI presentation, and right under it is the traumatic brain injury identification method training, and also the actual screener. So they can find that there. So they've screened and we've identified those consequences. Now, how should we address those effects of TBI in their treatment plans?
So, April, to me, there are 3 major issues that need to be kept in mind. Once you've identified, oh, this is somebody who has enough of a history that they're likely to have some of those problems, in terms of executive function weaknesses. So the first is that, and these all are things you should be in your thinking as part of your treatment planning, as well as your interactions with. And the very first is that they think about ways that you can just accommodate some of these neurobehavioral deficits. And we have some materials online, again, all free. April would have some, same or similar links on her website, just to give you an idea of how we've talked about it. We talk about accommodating the symptoms of traumatic brain injury. And by the symptoms, what we're talking about are these executive functions. So it's a person's attention, their speed of processing, their memory, but it's also these regulation of emotion and thought, like initiating and impulsivity, planning and organizing, mental flexibility, or even self-awareness. And what we do in our accommodations training is to go through all of these, so all 8 of these particular behaviors. And let's use speed of processing as a example. And we'll first define it. What is processing? In this case, it's how quickly one takes in new information and concepts. It doesn't necessarily mean they can't understand something new. It's just the time it takes. And somebody with slower speed of processing will interact differently in conversation and will struggle more, for instance, in group settings and that kind of thing, where the conversation moves a little bit faster. So and what we do is for speed of processing. So what might you see? What might a person with this problem show you? And it's maybe only picking up portions of instructions or conversations, having difficulty keeping up with the conversations I mentioned, tiring out because it's more work to stay up when you have slower speed of processing with what's going on around you. And so because they tire out, they may appear to have zoned out, and that might be misinterpreted as disinterest or being passive or unmotivated when it's simply fatigue, and not uncommon, maybe somebody being called lazy. So we talk about then, this is what you might see, so what can you do about that? And for accommodating the problems with processing, we make just some simple recommendations. And it starts with keeping it simple. Boiling down what you want a person to understand, in making it in doing it in bliss, and making sure that it's as simplified as possible. Then checking in. So don't just talk, check in, ask the individual what they've heard, what they understood. Do they, have them repeat back to you the instructions you gave or the ideas you were just talking about, so that you can actually check what they process. And just in general, slowing it down, whether it's to slow down your presentations, the speed with which you present things, speed with which a group, or if you're doing a didactic in a lecture, but also just in interaction, giving a person a few extra seconds to gather their thoughts, to make their response. So this is just one example of the kinds of things, for accommodating speed of information processing. And as you can see, there's nothing here that says that a person can't be involved in the kinds of treatment that you're providing. It's simply a matter of making adaptations to it so that they can take full advantage of it. So the accommodations is my first recommendation. The second is be ready for other kinds of issues. So if you're treating a substance use disorder, you're almost certainly going to have a psychiatric disorder as well, some depression, anxiety, if not a psychotic spectrum disorder, or vice versa, that we have the rates of prevalence of brain injury, history of brain injury in duly diagnosed populations, those with both severe mental illness and substance use disorder, is above 70%, so as many as 3 in 4. But you're also going to have some, medical-like issues, whether it's chronic pain or sleep disturbances, or maybe even seizure disorder. So, being ready for these comorbid interactions and being, welcoming the complexity rather than dreading it, is a second recommendation. And figuring out how you can integrate, these various problems a person is bringing into your treatment planning and how you approach an individual is important. And then finally, these individuals with these frontal lobe weaknesses from histories of brain injury need more attention given to the formal and informal supports that they're going to use during treatment and after. If there is a clinical truth that I've heard repeatedly from behavioral health specialists, it's that for people with brain injury, the gap between intending to change their behavior and changing their behavior is even greater than for other behavioral health clients and consumers. Now, there's a gap for all of us. I mean, if it's just simply a matter of saying, I'm going to stop this, then we wouldn't need, behavioral health care systems. There is a gap for everybody, but there's an even greater disconnect for the individual with a history of brain injury. And they may be fully committed to their change, but they are more susceptible to triggers from the environment changes in the environment, their social environment, such that they will, if we're talking about substance use disorder, relapse, if we're talking about psychiatric symptoms, have a a new episode of illness, just because they're more susceptible to the environmental influences. So these are the big three. This is obviously kind of 40,000-foot level, but think about how you can accommodate those neurobehavioral deficits, both in your communication as well as in all of the aspects of your treatment program. Be ready for these other comorbid conditions, and when you think about those supports, I sometimes say, when you think you're done with a person with traumatic brain injury, done in treatment, you're not. That it really, it's going to take longer for the behavior to change, to become habitual, and they're going to need more support over a longer period of time.
Thank you. Definitely. Thank you so much, Dr. Corrigan. We appreciate you being here with us today and doing some follow-up with us. It's just invaluable to us and to the mental health providers here around Alabama. We appreciate you. I do want to emphasize what Dr. Corrigan just expressed to us on the accommodating for the symptoms of TBI. We will have that on our website. alabamatbi.org is the website that we use for our TBI grant. It's supported through there. And we'll have that workbook. We do have workbooks as well. If you're interested and you need a workbook, we can provide one of those to you as well. Just email april.turner@rehab.alabama.gov. And finally, I would just like to ensure that if you don't take away anything today, that you understand that there is support there for you and your staff when it comes to learning about brain injury and the effects, the consequences, the behaviors. And we're there to support the survivors as well. So if you'll go to alabamatbi.org, you can find pictures of the specialists in the state, pediatric and adult, who work directly with those survivors right after injury. They could do consult, they could give you simple accommodation help as far as their treatment. Again, we need mental health treatment for our folks. We do a lot of in-house cognitive remediation, getting them on a schedule, getting them back and returning to school or work, but we need your help as far as the mental health side as well. So the two main things is alabamatbi.org. You can find trainings, you can find resources there, and we also have our hotline number that was in the beginning of the presentation. You're more than welcome to call that as well, or give that out to survivors or families. As well as rehab.alabama.gov/TBI, and it's in the beginning of the presentation as well. So thank you for being here again, Dr. Corrigan, and I'd like to turn it over to Judy to share with us some additional training on behavior that is also coming up that I would like the community health providers, substance abuse providers in our state to know about and to attend if they wish. Turn it over to Judy.
Great, thank you. And thank you both for such a great conversation about this important issue. I hope that other states will do the same thing that you're doing in Alabama, because we know that, again, that incidence rate and co-occurrence is so significant. And really, there are some very simple, as Dr. Corrigan demonstrated, accommodations and ways to think about supporting people with brain injury that will make your lives easier as clinicians and definitely improve the lives of people with brain injury. So thanks for having the conversation. If you are interested in furthering your education along these lines, NASHA is partnering with Craig Hospital out of Colorado, and they are providing a 6-series webinar, and it will go more into depth around some issues, specifically around treatment of people with behavioral health concerns and brain injury. You can see the flyer on your screen, and April, maybe we can have you post this, or it definitely is posted on our website at nasha.org if you want more information. But we will have a doctor talking a little bit about some of the pharmacological interventions that could be helpful. So if you are a psychiatrist or working with psychiatrists, that might be one that is of interest to you specifically. Looking at brain injury holistically from a medical perspective, and then talking about really adapting some of your traditional treatment modalities and how that could work in terms of supporting people with brain injury and their families. And Lisa Brenner will be talking about mild brain injury, and then we'll talk about neuropsychological assessment and brain injury. So it's really a rich series that will go into more depth and might just further your knowledge and education on this issue. Next slide, please.
And that's free too, Judy,
Oh,
correct?
yeah, thank you. Yes, it's free, and I believe they'll be recorded, and so you can access at a later date. And there will be some CEUs involved with that as well.
And
So
we'll
it's a
put
great-
that on our website.
Thank you, April. The other opportunity is the conference that we are putting on at NASHA. We have an annual conference, and this year's conference, of course, will be virtual, just like everything else is being virtual, but it actually has turned into a pretty great opportunity to bring in some presenters and speakers that we maybe otherwise would not be able to reach. We have a pretty significant behavioral health focus to this conference, as well as we have a post-intensive day that will focus on health disparities and health equity, which I think will be fascinating, and then sprinkling of other topics that might be of interest to you as well. So that you can find on our website, and more information about that at nasha.org. And if you have any questions, please feel free to reach out. So with that, I just say thank you again, April and Dr. Corrigan, for your work with this session today. We really appreciate it.
Thank you.
Thank you, Judy, and thanks again, April.
Yes.
Take care.
Thank you.